Yes, good afternoon, everyone. My name is Ibimina Dagogo-JACK, and I am a PGY3 of Internal Medicine in North Alabama Medical Center. And today my presentation is about a patient, and it's titled "From Being Diagnosed with Early Dementia to a Hospital Admission for Sepsis with Staph Bacteremia." And the great imitator would not stop confounding the medical community. And this is the journey of a 64-year-old man with neurosyphilis. I do not have any financial relationships to disclose concerning this presentation. So I'll go into the case presentation. This is a 64-year-old man. He presented with progressive clinical decline and lethargy. He does have a past medical history of type 2 diabetes, mellitus, stroke, and dementia, for which he was recently started on donepezil. 3 years ago, he was treated for primary syphilis, and a few months before recent presentation, he was brought in for confusion, increased somnolence, and myoclonic jerks. Basic labs and imaging were unremarkable at this time. LP and repeat RPR were not performed. On this admission, on the present admission, the neural function was not fully assessed due to his altered mental status. He did have some fever spikes and blood cultures grew staph, SPP. Brain MRI showed atrophy, diffuse atrophy. RPR, CMV, HIV serologies were negative. So he was managed with a 14-day course of empiric IV penicillin G and vancomycin. Unfortunately, he was ultimately transitioned to hospice care due to lack of improvement. So the discussion that we are having today about syphilis, neurosyphilis specifically, is that neurological presentations are common in the acute care setting, and they consist of numerous etiologies, infectious, inflammatory, and neurodegenerative causes, especially in the elderly. It could be acute, chronic, or an acute manifestation of chronic illnesses. Risk factors such as age, existing comorbidities, chronic medications may lead to confounding and biases. A high index of suspicion is therefore necessary in these atypical scenarios. Syphilis is often termed the great imitator because of its wide range of presentation and its effect on every organ system. Neurosyphilis is a subtype of tertiary syphilis affecting the CNS and presents as early, which could be asymptomatic meningitis, meningovascular syphilis or ocular syphilis, or late, which would be the general paresis, tabes totalis, or dementia. Neurosyphilis is a CNS manifestation, and it is obviously due to the Treponema pallidum organism. It typically develops in 10 to 25 years after initial infection, or in some cases may occur earlier, especially in immunocompromised patients. Dementia is associated with the late-stage neurosyphilis, and it is due to brain parenchymal invasion by the spirochete. The primary presentation is general paresis, which mimics psychiatric disease and Alzheimer's dementia, with features such as personality changes, forgetfulness, irritability, and a sleep-wake cycle disorder. Other possible neurologic deficits include intention tremors, limb hypotonia, and dysarthria. If left untreated, as was in the case before the availability of penicillin, life expectancy is less than 5 years after symptom onset. To conclude, in general, neurosyphilis has become increasingly rare again, like I said, due to curative effectiveness of penicillin therapy for syphilis. And for this reason, neurosyphilis infection can result in misdiagnosis due to its wide range of signs and symptoms, as well as confounding disease states with similar findings. Episodes such as confusion, delusion, agitation, disorientation, and even seizures pose additional diagnostic complications, especially when other foci of infection, such as staph bacteremia, as in our patient, are present. A negative RPR makes neurosyphilis unlikely, but then it doesn't rule it out. And in the right clinical scenario, an LP should be performed to clinch the diagnosis. Thank you very much. I welcome any questions at this time.
Alrighty, thank you very much.
All right. Thank you.